Okay. I'm going to get started for the guys of time with my little discussion. We're going to have our virtual stroke support group. We have it set up one Thursday a month. We're offering it this way to allow for more people to have access to the support group, especially those who are bedbound and at home. So our goal overall is to help reinforce discharge information while exposing stroke survivors and their caregivers to current information on how to navigate life after stroke through virtual monthly talks. If anyone has any suggestions, you have the stroke support at halifax.org email address, and you can send me an email and let me know if you have any interest of seeing any different type of topics other than the ones that we're discussing. And I'm going to be turning over the view to Elvia Cortes, who is here for having a discussion regarding the managing of carotid surgery and stroke prevention. And we're super excited to have her. Welcome.
Thank you. Thank you.
And then you got the share. You're going to share your slide presentation.
Yeah. All right. Can everyone see that? All right. So thank you for joining, everyone. My name is Elvia Cortes, and I'm a vascular surgery nurse practitioner here at Halifax Health. I have the lovely honor of working with two amazing surgeons, Dr. Robert Fieser and Dr. Michael Yakub. And so today, let's go ahead and get started. We're going to talk about carotid artery disease. And so I think it's very important to talk about this as a stroke support group because carotid artery disease is one of the leading causes of stroke. So about 30 to 40% of strokes are caused by carotid artery stenosis due to the plaque that builds up in the artery, which can occlude blood flow to the brain. So what is the function of an artery? And what are we talking about when we're talking about carotid arteries? So the function of the artery is actually, it delivers oxygen-rich blood from the heart to the tissues of the body. So carotid artery is located here. I just want to show you guys a little diagram. So where this green area is, it's the right common carotid artery. This is looking at the right side. It bifurcates, meaning it kind of branches out. Where the yellow is, that's the right external carotid artery. That actually, that function is to actually supply the blood flow to the face. But when we're talking about carotid artery disease, we're really looking at the internal carotid artery because as you can see, it travels upward, and that's one of the main arteries that supplies the blood flow, the oxygen-rich blood flow to the brain. And over here on this diagram, when we talk about stenosis, what we're looking at is the plaque formation that can absolutely kind of block or obstruct the flow, or sometimes it can occlude. So how do we get plaque formation in arteries? What are some of the causes or risk factors? So smoking is the #1 risk factor because I actually looked this up. There's 600 chemicals in one cigarette, which I found kind of interesting. It can actually build up plaque a lot faster just by those chemicals. In addition to, it actually constricts the blood vessels, the main arteries. So every time someone inhales a cigarette, it actually is causing that constant constriction motion. And if you've got plaque formation already built up in the artery, it's just a recipe for it to occlude and to block. High blood pressure is another risk factor. And what that does, so if it's uncontrolled high blood pressure, it actually damages the artery, the inside, the lining from that constant movement. And it actually can cause it to become more vulnerable and causes that plaque formation to build up. Another risk factor is family history, age, obesity. High cholesterol levels in the blood can absolutely cause that formation to happen a lot quicker. And another one that I found very interesting too that a lot of patients don't really, they kind of get surprised is if you have uncontrolled diabetes, high blood sugar circulating through the circulatory system absolutely causes an increased amount of plaque formation in the artery. So basically, carotid artery stenosis is most often diagnosed as an asymptomatic finding. And so often because of a duplex ultrasound, an MRA, or a CTA that is performed for vague neurological symptoms, usually not directly attributed to carotid artery disease. Or if sometimes what I find with a lot of patients very similar is when they go to a provider and they hear on exam a carotid bruit, which is basically a swishing sound heard by a stethoscope on the neck, which can mean that there's some kind of disturbance in the flow. Or if your provider thinks that you've got the risk factors and they've sent you off for a screening. So how do we diagnose? How do we diagnose carotid artery disease? Looking at this picture, don't laugh, but that's actually our senior partner, Dr. Fieser, and our sonographer, Amanda, she had a really good hair day. And that's me, the patient, and so I'm trying not to laugh. It kind of tickled. But carotid ultrasound is one of the main testing that we do. It uses sound waves to examine the blood flow, and it calculates the velocity. Velocity meaning it's the speed of something given in one direction. So it calculates the velocity of blood flow to determine the degree of narrowing. So the higher the velocity numbers that you get, the more narrowing that you have. Another wonderful test that we do is a CT angiography, which is a CTA. Now that's basically a glorified CAT scan that visualizes the internal and external carotid arteries used with dye. So sometimes if a patient has a contrast allergy, they're allergic to the dye, we have to either pre-medicate them, or if someone has chronic kidney disease, sometimes it doesn't allow us to get this exam. Or an MRA. An MRA uses more of a magnetic field, radio waves, and it creates images to look at the soft tissue and bones and some of the internal structures. And it's not really good for patients that are claustrophobic. This is the one test that a lot of patients kind of get nervous if they have a fear of small spaces. And sometimes it actually overreads and it kind of does some shadowing. So really the CTA and the ultrasound are pretty sufficient. So once diagnosed, what do we do? So one thing that I want to do in our practice, what I always look for is medical management. I want to make sure that they're on the right medication. And one of the main medications that I want to make sure that you're on is a statin. A statin is actually a medication that lowers cholesterol levels in the blood by inhibiting the synthesis of cholesterol. So Lipitor, Crestor, Zocor, Provocol are some of the simple ones that are mainly that you'll see a lot. And there are studies that actually have proven and shows that it stabilizes the plaque. What does that mean? It actually helps smooth out the plaque formation in the arteries, makes it more stable, so less likely for it to flick off and cause any events. And so sometimes, though, too, there are about 20 to 30% of the population are intolerant to statins, and we don't know why, but some patients are. And when I mean intolerant, they have a side effect called a myalgia, which is basically muscle cramping. And so the more that they ingest a statin, the more severe these muscle cramps can be. So we have to definitely make sure that they can't take them, so we call them intolerant. So I definitely want to talk about some alternatives that I see in the field if someone is intolerant. So Welchol is one of the main ones, and it absolutely is a lipid and glucose lowering agent. It helps reduce cholesterol by producing more agents in the body to bind to the cholesterol. So for someone that has type 2 diabetes, in addition to high cholesterol, this is a wonderful medication to talk to your provider about. Another one is Celestid. It helps reduce cholesterol by producing more bile sequestration. So it binds to bile in the intestine, which converts that cholesterol into bile acids, therefore reducing the cholesterol levels. And another medication that I see a lot too is niacin. And that's a natural B3 agent that basically aids in reducing cholesterol by breaking down carbohydrates and fats and lipids. Now, the one thing you do have to be careful and keep an eye on, you want to make sure you're on the right dose, and that's why we want to make sure that your provider knows that you're on this, because high doses of this can absolutely damage your liver. And then another medication I want to make sure that patients are on when they have carotid artery disease is blood thinning agents. This decreases the likelihood of clot formation. So I have antiplatelets and anticoagulants. What's the difference, right? An antiplatelet, like aspirin, Plavix, you'll see a lot, Effient, Brilinta, those basically are antiplatelets. They prevent blood cells from clumping together to form a clot. And then there's something a little bit stronger, like an anticoagulant, which basically slows down the body's process of making clot by reducing the fibrin in the blood. So what I find, patients that are on these medications like Eliquis, Xarelto, and Coumadin, a lot of times patients are on this because they have other different underlying conditions like AFib, or, heart disease. And so just by being on these two medications, they're called cardiovascular risk factor modification meds. So blood thinning agents, clearly basically easy to circulate through the blood flow when you have blockages or if you have any kind of narrowing in the arteries. And then the statins that actually help smooth out the plaque in the blood flow. So by staying on these two medications, it's preventing future strokes, future heart attacks, because the coronary arteries, they can absolutely get plaque formation, and then also preventing peripheral vascular disease. So symptoms. What kind of symptoms do people have when they have carotid artery disease? Symptoms like syncope, mild headaches, lightheadedness, dizziness are not considered to be indications for carotid artery disease. Typically, patients are asymptomatic. They don't really know that they have it, or it's something incidentally found by exam. When patients are symptomatic, when we consider patients' symptoms that they have symptoms, is usually an acute headache, the worst headache that they've ever experienced, called like a thunderclap headache. Total vision loss, like a curtain has covered your eyeball. Slurred speech, one-sided weakness. So basically stroke-like symptoms, because basically plaque has slipped off into the brain and has blocked the blood flow in the brain. So what do we do when someone needs a sort of surgical intervention? When do we decide? It's when they have high-grade stenoses or they're symptomatic. So what kind of interventions do we do? One of the main ones here is a carotid enderectomy. Now this is a surgical procedure that is performed to remove the plaque from the inside of the carotid artery. This helps restore normal blood flow to the brain and prevent a stroke. So looking over here, back at that anatomy slide, this right here is the internal carotid artery that supplies the blood flow to the face. Now this right here, the carotid enderectomy has already been performed. There's an incision that goes right over here. We open up the artery, we remove the plaque, and then sew the artery back up and patch it. Patients do pretty well with this, and there is a 99% chance that this is a one and done surgery. We don't ever have to go back and do this again, but there is that 1%. But it's a pretty durable surgical intervention. Another intervention is a transfemoral stenting. Now this delivers a stent into a blocked carotid artery from the groin, but there is a risk of causing a stroke is higher with this than the traditional CEA, which is the carotid enderectomy. But this still is used for certain circumstances. And another surgical intervention that we do is a transcarotid artery revascularization, also known as a TCARV. Now this delivers a stent into a blocked artery as well. But what's interesting about this, the device itself decreases the risk of stroke during the procedure by reversing the direction of the blood flow away from the brain, less likely for any of that plaque debris while we deploy that stent to travel upward to the brain. And this is usually considered when patients are at high risk for a carotid enderectomy. So surveillance. What I always tell patients, surveillance with carotid arteries or in general, once a vascular patient, you're always a vascular patient. We get very close to our patients. There's only one way out of our practice, and I'm not going to tell you how that is. So with carotids, usually it's a yearly surveillance, or depending on the degree of the narrowing or the stenosis. Sometimes it's every 6 months if you're getting closer to that high-grade stenosis where we may be thinking about doing a surgical intervention. Or if someone has stayed stable and have had many readings where it hasn't really worsened, then we can see you safely every year, as long as you're medically managed with those two medications, statin and a blood thinner. After surgery, we do see you a couple weeks afterwards with a carotid enderectomy just to make sure that everything is flowing, whether a stent was placed or whether we did the carotid enderectomy. And then after that, then we usually see you every 6 to 12 months. So how do we prevent carotid artery disease? Prevention is basically smoking cessation. Do not smoke. It's the #1 risk factor. Or cut back or limit the amount. Exercise. You want to walk daily, 5 to 10 minutes. I always tell people don't have these grandiose plans where you're going to go to a gym and go 5 days a week. Who's got time? So start with a commercial break, 5 to 10 minutes. Get up, commercial starts, go for a walk to the mailbox and back, and then increase your time over time. We live in Florida. We have the luxury of being surrounded by water. Swimming is wonderful, especially for patients that are limited with activity. They have arthritis. Swimming is a wonderful activity. Bicycle riding. And so with increasing exercise, we definitely want to maintain, that will help maintain a healthy weight. And healthy diet. Eat more vegetables. Don't laugh, but that is one of the main ones. Eat more fruits, less salt intake, and limit the cholesterol and fat intake. And that is carotid artery disease.
That was wonderful. Does anyone have any questions? Any concerns about the discussion? Anybody want to add anything or have any further information? Yep.
With the transcarotid revascularization and you're diverting blood flow up to the brain, how long is that for?
Oh, the surgeries usually take, well, it all depends. It's usually before they deploy the stent. And so these surgical interventions can take anywhere between an hour to an hour and a half. So really, it all depends. It all depends.
Sorry, I might have misinterpreted. You said you were with the blood flow, you're reversing the direction of the blood flow?
Yeah, so the device itself goes in, and then it helps reverse that blood flow. So with a traditional carotid enderectomy, we would just clamp, right? Okay. And so with this one, there's a device it kind of helps reverse that flow, so it's keeping it away from it going up. Because usually when we do a carotid enderectomy, you're clamping, before we unclamp, we have the flow go downward first, and then, before we,
Okay. And then
restore the blood flow to the brain.
Gotcha, okay. And how long do you keep the blood flow reversed?
That I would say I don't really know to answer that one. I'm not sure, because it's usually case by case, but no, I can see. I'll have to get back to you on that one.
I could probably interject with that as well. Like with the circle of Willis, we get backflow into the brain. Yeah. So the other carotid is still in the brain at the time. So it's just to help remove the clot. When they remove that big cloppy like fatty plaque, right? They need to slow the flow so they don't have any little tiny particles go. And I think in that device there might be a reverse fan that is either a suction or a fan that helps hold the flow backwards so that you can actually remove the invasive material that's in the artery at the time. Gotcha. And then the backflow goes with the circle of Willis to help backflow the brain. So you're not stealing anything from the brain.
Okay, that was what I was getting at. Thank you.
You're welcome. Is there any other clarification for anybody? Well, that was an awesome discussion. We will be back with another discussion in another 4 weeks. Every month we do a presentation virtually. We have a schedule, so you can either email me or I'll keep the emails that I have and forward you a new invite next time. Elva, that was amazing. I loved your speech. That was wonderful.
Oh, thank you. And thank you guys for joining in tonight. I appreciate it.
Yeah, thank you very much. That was great.
No, thank you.
Thank you.
I'll be recording it and hopefully sharing it with, maybe we'll see about getting this and the one that we did prior on our Facebook page so other people who haven't seen it can see it. Well, if there's nothing further going on, I want to give everybody the rest of their night back and thank you very much for attending. Okay, have a good day.